officially at 12:01 p.m. according to my little computer clock. And we'll give folks a few more minutes to filter in. Filter into the room. They're out chatting in the hall, don't you know? This is the August 16th Consortium of Lake Area Senior Services Lunch and Learn. We're super stoked to talk about strokes with Jarrelle Waldorf and Jodi Peterson, who both come to us from Allina Health, talking about the various aspects of strokes and before, during, and after. Well, I don't know if it's all three of those, but we're really glad to be here. My name is John Slade. I'm the co-president currently of class. Scott Olson, who's also there waving his hand, and I are the co-presidents. Kate is driving around. She is our secretary. And various other folks are here, board folks here as well. For, well, we've still got a little bit of filtering in time here. Julia and Georgia and Charlotte, do you want to just introduce yourself? Say, hey, where you are and where you're from?
Sure. Julia Wolf. I lead the Healthy Aging Initiative at St. Paul Ramsey County Public Health.
Georgia, are you able to say hey?
I am. Hopefully I'm not echoing.
Still echoing.
Still echoing. I should make it quick. So Georgia Afton, Friends and Co. Community Outreach Director.
Excellent. Charlotte, are you able to pop on and say hey? I saw some turning on, turning off of things. All right. Well,
Actually, I'm sorry, John. May I say one more thing?
Yes.
I have to leave at about 12:27.
More or less, exactly. Yes. Okay. Well, we'll enjoy your presence between now and that time. Hey there, I see you, Charlotte. Charlotte, are you able to say hi and introduce yourself?
Can everybody hear me? I'm Charlotte Hoos, and I work with Care Options Network here in the Twin Cities, and I know many of the members of this group are part of the Care Options Network. We provide resources about services and housing for seniors and older adults, and lots of different people in and around the Twin Cities. So if anybody is interested in being part of that membership group, I'd be happy to talk to you. We'd love to have you as part of the membership. Again, it's like a consortium. We're stronger because we're all together, right? So thanks for hosting this today. It's a great topic.
Absolutely. If you want to put your link or name or anything in the chat, feel free to share that and share that around. Well, it is now 5 after, which in my MICA chapter, we're the Metropolitan Interfaith Council on Affordable Housing. We give folks 5 minutes. That is 5 minutes. Jarrelle Waldorf, MSN, RN, CEN, and TCRN. That is you. Take it away, Jarrelle.
That is me. I probably need a little more alphabet soup after my name. So my name is Jarrelle. I'm the stroke program coordinator at United Hospital in St. Paul. I do have with me my colleague Jodi Peterson, and I'll let her introduce herself.
Hi, my name is Jodi Peterson. I'm the therapy supervisor for all of the inpatient rehab and acute care, physical therapy, occupational therapy, and speech therapy here at United Hospital.
So today we want to go over all things stroke. We're going to go over a definition of stroke, review some stroke statistics, stroke signs and symptoms, risk factors, and some things that you can do to lower your risk of having a stroke. And then Jodi's also going to talk about rehabilitation therapy and stroke recovery. And then at the end, I do have some additional resources that you guys might find helpful. Please know I am pretty informal. If you have questions, stop and interrupt, ask as they come up. I will try and keep an eye on the chat. That is not my strong point, so I highly encourage just unmuting and letting me know. Otherwise, there is time for questions at the end. So we're going to start with what is a stroke. Stroke occurs when the flow of blood and oxygen to the brain is stopped or interrupted. This happens because of either a burst blood vessel or a blocked blood vessel. So there's a couple of different kinds of stroke that we'll talk about. The brain needs a constant supply of blood and oxygen because without that blood and oxygen, your brain cells start to die, and that's what causes your stroke symptoms to start appearing. Stroke can cause serious disability and can be life-threatening, and stroke is an emergency. This is the time to call 911 and come to the emergency room. In the U.S., stroke causes approximately 140,000 deaths each year. That's about 1 death every 4 minutes. It is the 5th leading cause of death in the United States and the 6th leading cause of death in the state of Minnesota. It is the leading cause of adult disability. More than 800,000 people in the U.S. suffer a stroke every year. So 1 person every 40 seconds has a stroke in the United States. In Minnesota alone, about 11,000 Minnesotans are hospitalized each year due to stroke. And then for those of you that have a loved one with a stroke, you are not alone. There are over 100,000 stroke survivors living in Minnesota today. So we're going to move into talking about types of stroke. There's 2 main types of stroke. One is called ischemic, which is a clot or a blockage, and the other is hemorrhagic, which is when there's bleeding in the brain. So I'm going to try and incorporate some medical terms with some quote-unquote normal people speak. If I get too medically, let me know. So with ischemic stroke, this is the one where it's the blockage. This accounts for about 87% of strokes. So this is the most common type of stroke to have. Within that, there are thrombotic strokes, which are fatty deposits or plaque that attach inside of artery walls and narrow or close the artery. And this plaque buildup can cause or create a narrow vessel, essentially, which is easier for a blood clot to stop the flow of. And you can see the picture there on the right-hand side of a thrombotic stroke. So the vessel wall outline and then kind of the jagged white peaks and valleys there, that would be the plaque. So you can see how narrow it creates that vessel, thus making it a lot easier to block off. Another type of ischemic stroke is called embolic. This one is when a small blood clot forms in any body part and travels to the brain. These ones, the blood clot often travels from the heart. And you can see in the bottom right-hand side there what that embolic stroke looks like, where that little tiny blood clot just blocks off that part of the vessel. Something that's getting a lot more commonly talked about are transient ischemic attacks, or TIAs. Sometimes people call these a mini stroke or a warning stroke. The stroke symptoms go away. So these ones don't typically cause brain injury, and the symptoms do not last. That said, the symptoms might last a few seconds, a few minutes, a few hours. There's no really knowing if the symptoms are going to go away or not. If you have had a TIA or transient ischemic attack, you are at a much larger risk for having a stroke later. And then it is vitally important to remember TIAs require the same immediate attention as stroke. When your symptoms start, you need to come to the hospital. Until your symptoms go away, we don't know that it's a TIA, and we often have patients whose symptoms wax and wane or come and go, and they may be treatment candidates if you come in time. The other kind of stroke is a hemorrhagic stroke. This is the one with the bleeding in the brain. 13% of strokes are hemorrhagic, and within these, there's a couple of different kinds as well. So there's a subarachnoid hemorrhage, which is when blood leaks into the space between the brain and the middle membrane that covers it, because you have 3 membranes in your brain. The most common cause of a subarachnoid hemorrhage is an aneurysm. So these ones, the aneurysm is like a little bulb in the blood vessel that gets weakened and it ruptures or breaks and causes bleeding in that space. The other kind of hemorrhagic stroke is an intracerebral hemorrhage. This is when small blood vessels in the brain burst and leak, causing bleeding in the brain. A common cause of this one is high blood pressure or hypertension. Depending on which part of your brain is affected by your stroke, you can see here different parts of your brain control different things. I'm not going to go deep into the anatomy today because that's not why we're here, but I do think that is something interesting to know, just given, especially if you look at like the occipital lobe in the back that controls your vision, or the temporal lobe that helps control language and memory. So if you have a loved one who's had a stroke or any kind of brain injury, you can see where their injury might be in the brain, depending on the symptoms that they have. So this graphic, with stroke, we have an acronym, Be Fast, and you can see it on the screen in front of you. These are like the I must know this and pay attention time. B is for balance. This is a sudden difficulty with balance. It can often be confused with like a vertigo. So we do stroke workups with patients with vertigo sometimes. But this is something where you're walking along and all of a sudden it's like you're on a boat, but you're not on a boat. E is for eyes. Sudden problem with vision in one or both eyes. This can be a few different things. This can be double vision, blurry vision, or you can have complete loss of vision sometimes, or you might even have it where you don't see anything on the right or anything on the left. So this is like a visual neglect. The F is for face or facial droop, when the smile droops on one side. This one you think of often on TV, especially. When you think of like a quintessential stroke patient, you think of someone who has that one-sided facial droop. The A is for arm or leg weakness. This is also sudden onset. And with these ones, this one might be weakness, it might be tingling or numbness, or an inability to move that limb altogether. The S is for speech. So you're unable to repeat a simple sentence, or your words are slurred. This might also come across as stuttering speech, or the inability to understand what's being spoken to you, or for the other person to understand what you are saying to them. So you guys are having a conversation, and all of a sudden, it makes no sense. You're talking about lunch, and then all of a sudden, it's koalas. And then the T is for time. If you observe any of these symptoms, call 911. Stroke is an emergency. And we'll get into the reason why we recommend coming by EMS and not coming by private vehicle here in the next few slides.
Jarrelle,
Yes.
Mitch McConnell was giving a speech and stopped and walked away suddenly. Could that have been a TIA speech stroke?
It absolutely could have been. My understanding is there was a lot of speculation on the internet that that's what it was. Not being involved in his care, I obviously couldn't say for certain. But yes, there's been a few people on the news, and I think a newscaster recently even who experienced a stroke on live TV.
Wow.
So the part of the reason we want you to call 911 and what to tell them and what to expect. So you want to tell 911 you are concerned for a stroke, whether it's you having it or a loved one having it. You want to tell them what your stroke symptoms are, what time you were last known well or quote unquote normal, whatever that means anymore. So this is really important. If you wake up with stroke symptoms, a lot of times people will say, well, I was last known normal at 6:30 because that's when I woke up. However, if you woke up with those symptoms, the last time you were known normal or known well is when you went to bed. It's not when you woke up, unless you woke up normal and the symptoms started like while you're eating breakfast or drinking your morning coffee. You'll also want to tell them your important health history, especially if you take anticoagulants or blood thinning medicines. Some examples of these would be warfarin, Coumadin, apixaban, Eliquis, Xarelto, etc., depending on if you use the name brand or the generic brand or name. When EMS arrives to you, you can anticipate that they'll do an exam. They are probably going to have you smile because they want to see if you have the F of be fast, right? And sometimes when people aren't necessarily paying attention because you're stressed and it's an emergency situation, they may even say, smile so that you show me your teeth, because they're really trying to see, is it equal? Do you see the same number of teeth? Do you see the creases? Are those the same? They will ask you to lift your arms. And this might sound silly, but they're going to ask you to lift both arms at once. And what they're looking for is they're looking to see, do your arms drift? Does one of them drift, right? So is one of them really strong and the other one is wavering or doesn't lift up at all? And then they'll probably ask you to repeat some kind of simple phrase. An often one that's used is, the skies are blue in Texas. There's enough S's that usually you can determine if someone might be slurring their speech. And that's really what they're looking for with that. That says they understand me, they're following commands, and lets them evaluate your speech, all in one simple sentence. They're going to take your blood pressure. They are probably going to poke your finger and check your blood sugar, because low blood sugar can mimic stroke-like symptoms. So can really, really high blood sugar, but the low blood sugar is the one that we can fix, and if we fix it and the symptoms go away, then we know it was just a sugar problem. They're most likely going to start an IV, and most importantly, they're going to tell us in the emergency department that you're coming. They're going to say a few minutes before you get here, we have a stroke code activation, or we have a stroke patient that's coming in. And that is going to activate a bunch of resources at the hospital internally so that we're ready for you to get the treatment as fast as possible. Time is key to treatment options. Time is key. When you get to the hospital, at most area hospitals, especially within Alina, you are likely going to go from the EMS stretcher right to the CT table. People who are probably going to be there waiting for you. It's going to be like you're famous in a way that you don't want to be. But you're going to have likely an emergency department provider. A stroke neurologist will be there likely in person or via telestroke, depending on what hospital you show up to. You're likely also going to have an emergency department nurse, a CT tech, who's an imaging tech. They run that big fancy magic donut looking thing on the right-hand side there, and a pharmacist. They're going to do a medical assessment. They're going to ask you some of the same questions that EMS did with the smile, the arms, the speech, and the statements. They're also probably going to say, like, squeeze my hands, lift up your leg, things like that. And then it'll take just a few minutes to do that CT. You can see it's pretty open, so most people don't get claustrophobic in it, and that's what gives us a picture of your brain. That CT imaging, as well as the time that you're last known well, helps us determine if you're eligible for treatment. If you are, treatment options will be discussed with you and or your family, as well as any risks and benefits reviewed, because it's important to make a decision knowing all the information that you can. So the treatment options for ischemic stroke. Like I said, with stroke, everything is time sensitive. So if you are last known well within 4.5 hours, which is why it's really important that I differentiate between when you went to bed versus woke up, if you woke up with the symptoms or if they started after, you might be eligible for what's called a thrombolytic or a clot-busting medicine. There are a couple different ones on the market. The one that we currently use is called tenecteplase, or TNK. Then if you are within 24 hours of last known well or last known normal, depending on how big your stroke is and where it's located, you might be eligible for a special procedure called a mechanical thrombectomy. This is done by doctors with immense training. They're called neurointerventional radiologists. They're specialty providers, and they can actually take you in to an IR suite and go in and kind of suck the clot out to restore some of that blood flow and give the best chance of recovery. So the mechanical thrombectomy, it can be done whether you can get the thrombolytic or clot-busting medication or not. So it's a completely separate decision process from that thrombolytic medicine. Now, if you're a candidate for either of these, the stroke neurologist will collaborate with the team of care providers and the patient and family on which treatment option is best, but treatment's dependent on multiple factors, so not all stroke patients will be eligible for treatment. Like I said, some of it depends on the size of the clot, where the clot's located, and then there's more factors like your medical history as well. I can just skip this. So how important is time? I know I keep harping on this, but time is brain. So shortening your time to treatment is better outcomes. It can be up to 2 million brain cells per minute that die as you're delaying treatment, if you're treatment eligible. So with every 15-minute delay in getting that clot-busting drug, if it's something that you're eligible for, there's a 5% increase in relative risk of death. And then there is a 10% absolute reduction in good outcomes for every 30-minute delay in endovascular treatment, or that special procedure called mechanical thrombectomy, where they can suck that big clot out. So key points here. If you think you are having a stroke, be fast. Not only is that the signs and symptoms, fast action saves brain function when you're having a stroke. Don't wait. There are several treatment options for stroke, but they work the best in those first few hours. The faster we can get you treatment if you're eligible, the more likely you are to decrease your deficits and have a better outcome. And call 911. I know people like to avoid EMS whenever possible, but this is the time to use them. So we're going to talk about some stroke risk factors, because up to 80% of all strokes are preventable through risk factor management. We'll end up going through most of these, but as you can see here, this is a pretty decent list of risk factors. There's some that you can't control, but some that you can have an impact on to decrease your overall risk. High blood pressure or hypertension is the leading cause of stroke. Ask your healthcare provider about what blood pressure is right for you. For a lot of people, it might be like a 130/80 or a 120/70. Or for some people, it might even be as high as like a 160 systolic for that top number. This is why it's really important to have that discussion with your healthcare provider. Whatever that discussion entails, you want to make sure you're managing your blood pressure, and if you're prescribed medication, take it like you're supposed to. This is key. If you have diabetes, control your blood glucose. So ask about a hemoglobin A1C when you see your primary care doctor. This is a blood test that shows the average blood sugar control over the last 2 to 3 months, and it shows up as a percentage. Note that these percentages come specifically from the American Diabetes Association and American Heart Association. Each hospital, how the percentages are reported out and interpreted, they might be slightly different numbers, and that goes with any testing lab. So less than 5.7% on an A1C is generally considered normal. A 5.7 to 6.4% indicates prediabetes. So there's usually some changes you can make, whether that's diet or exercise, multitude of other things. And then 6.5% or higher indicates that you have diabetes. So within that, make sure you're eating healthful foods, get regular exercise, and trying to maintain a healthy weight. Next risk factor is going to be atrial fibrillation, or an irregular heartbeat. This one that you can see on the screen kind of shows you what that looks like. You have the normal heartbeat on the left, where everything pumps really well together, whereas the one on the right, those 2 chambers on the top, they just kind of quiver. And so when they're doing that quivering motion, it's not ejecting all of the blood out of your heart every time, and this leaves space where blood can pool in your heart and clots can form, and those ones travel to your brain. With atrial fibrillation, there's a few different ways that they might medically manage it. There's one type of medication class that's called an anticoagulant or blood thinner, and this one helps to prevent the formation of clots. And then depending on what's causing your AFib or atrial fibrillation, they might give you a medication. Often it's like a beta blocker. It ends in LOL, and that can help with rate control and sometimes keep you in a more regular rhythm. Did I hear someone start to ask a question? High cholesterol. Cholesterol is a fat-like substance made by your liver and found in the foods you eat, and there's a couple different kinds of it. The HDL, or high-density lipoprotein good cholesterol, helps get rid of extra cholesterol in your blood. Higher HDL levels decrease your risk of stroke and heart disease. So if you get a lipid panel or a triglyceride test in your blood work and you see your HDL numbers are high, that's great news. Low-density lipoprotein, or LDL, is the bad cholesterol. This is the kind that causes the plaque to build up and form and block your blood flow in your blood vessels. So these LDL levels, if they're higher, they might increase your risk of stroke and heart disease. And you can see over here on the right-hand side, another picture of that. That vessel on the top is open and blood flows through really well, whereas that vessel on the bottom, you can see all those little white kind of globules. Those are plaque buildup, and that makes it harder for the blood to come through. Another risk factor is heart disease, and there's a few types of this, including heart failure, heart valve disease, and coronary artery disease. Managing your weight can also have an impact on your risk for stroke and heart disease. So a lack of exercise increases your risk for stroke, high blood pressure, high cholesterol, heart disease, and diabetes. We generally recommend for patients who have had a stroke to try and get 30 minutes of exercise, whatever that may be for you, at least 3 to 5 times a week, or work with your provider to get there. Nutrition, we recommend a Mediterranean diet, which is an eating pattern based upon foods grown around the Mediterranean Sea. This includes whole grains and legumes, healthful fats like olive oil, nuts, fatty fish like salmon, tuna, halibut, etc., and lean proteins like skinless chicken and turkey, eggs, lean beef, and lean pork. We also recommend to drink plenty of water. Another important piece
But I'm muted,
is
so if you need anything, let me know.
tobacco use.
Actually,
alcohol.
Julia, you're not muted. Now you are. I'm sorry.
I'm not?
No, you're not.
But
I had to mute you, Julia.
because we just got into the good Mediterranean diet part and drinking water. I'm like, all the good stuff. Like, I could do that. That's all good.
Well, I mean, especially with that picture, it makes it look like a nice, amazing situation. So with tobacco use, alcohol, and drugs. Tobacco use, smoking, doubles your risk of stroke. So if you smoke, stop, work towards that. I know it's easier said than done. Have conversations like that almost daily with people. With alcohol, general rule of thumb for overall health, it's recommended for men to not have more than 2 alcoholic beverages per day, and for women to not have more than 1 alcoholic beverage per day. And then with drugs, don't use them. Or if it's prescription medication, use them as they're prescribed. And absolutely one of the hardest things that people do, I agree, is to quit smoking. I have family members who have quit and then gone back and quit and then gone back. But every step that you take towards stopping use of tobacco has a significant impact and greatly improves the long-term outcomes for your health, as you may have already even started to experience since quitting. So some risk factors that you can't control. You can't control your age. You can't control when you were born. We have to blame your parents for that. Stroke can happen to anyone, even kids. I have seen young children with strokes as an emergency department nurse, and strokes are more common in adults over the age of 55. Family history, you can't control that your grandparent, parent, brother, or sister had a stroke. But if they have, you're at higher risk for stroke, especially if their stroke happened before they were 65 years old. Race, unfortunately, a lot of our minority populations have a higher rate of death or disability due to stroke and just a higher incidence of having them. So Black adults have the highest rate of death due to stroke. And then if you've had a previous stroke or TIA, having one increases your risk of having another. Nearly 1 in 4 strokes occur in people who have already had one. I put a stroke risk scorecard on the screen, so I'm just gonna leave this up for about a minute, and then I'll move on to kind of show you how it's categorized with high, medium, and low risk. And I can include this as well in the attachments that I sent, absolutely. All right, so you can see I also included the risk factors on the bottom here, but you're considered a high risk for stroke if you have 3 or more points in that red or high risk column. So if you have those, you want to talk to your primary care provider about stroke prevention right away. If you are more in the blue column with 4 to 6 points in that column, that's great. It's a really good start. There are likely some things you can do to continue decreasing your risk of stroke. And if you're primarily in that green column, then heck yeah, you're doing amazing. You could probably help teach the rest of us some stuff. So overall, for stroke prevention, get regular checkups. If you don't talk to your doctor, you don't know your blood work, you don't know your blood pressure, there's a lot of things that you can't control or prevent. Talk to your doctor about any health concerns you have. If you start feeling short of breath or you feel like your heart is fluttery, things like that, those are important things to bring forward. Take your medications as prescribed. Stop smoking. We love acronyms in the world of stroke and medicine. So in addition to that Be Fast acronym that we have for stroke signs and symptoms, this one for brains can help also remember some of your risk factors and how to control them. So B is for blood pressure control. R is reducing cholesterol, fats, and salts in your diet. A is anticoagulants or antithrombotics. This specifically relates to medications. I is for increasing activity. Even if it's just a little bit every day, something is always better than nothing. N is for no tobacco or drug abuse. And S is for sugar control or blood glucose, depending on what you call it. Now I'm going to turn it over to Jodi to talk about some of the rehabilitation following a stroke.
Swap out chairs here. Before I get started, is there any questions for Jarrelle about any of the stroke signs and symptoms or medical management? Thank you for welcoming me. All right, I'll get started. I'm going to talk a little bit just about what it looks like after maybe going through a stroke and kind of how we approach it and walk through it as a rehab group. So typically we break down post-stroke rehabilitation into 3 different phases. So we consider the first phase to be the acute phase, which occurs all in the hospital. So this is from really the moment that you're having the stroke until you get discharged from the hospital. It really encompasses some of that early mobilization, identification of impairments. It could be doing a fair amount of walking and things like that, or it could be pretty limited because of other impairments that are happening or other diagnoses that you're dealing with too. The second phase is called subacute or a transitional phase. So this occurs from when someone is discharged from the hospital until they are discharged to a community place. So that could be a transitional care unit, it could be to a group home, it could be back home. So there's a few different places we talk about when we talk about the community. And then there's the last or the third phase, which is the outpatient phase. And the outpatient phase can really be a lifelong duration, which nobody likes hearing, but the truth is that any deficits that happen from a stroke could, you know, as we age, they can change. So something that maybe wasn't so bothersome in the 40s or 50s, as we get into the 70s and 80s, becomes a little bit more of an issue because of weakness that we're experiencing or loss of balance that's natural with aging. And so it primarily, we hit it the hardest right after discharge to the community, but again, It's something that we introduce as we are kind of your lifelong friends, whether you want us to be or not. We're going to see you from time to time throughout the rest of your days, potentially. So in the acute rehabilitation phase, so when we're seeing somebody in the hospital, typically we're going to see somebody that had a stroke within 24 hours, which can seem really, really quick. Sometimes when we walk into a patient's room, the patient and or the family are kind of like, are you kidding me? Like, you're actually going to get us up and move already. But time is the theme for all strokes. The faster we can get moving, the better it is, the better outcomes that we're going to have. And we work very, very closely with the stroke neurology team to make sure that we are not coming in too early. We want to make sure that medically the stroke is managed and we're not going to cause any harm. By all means, we don't want to be that person that's inflicting any more harm on anyone. So we work really collaboratively with that team. There's 3 different therapies that you will see after having a stroke. The first, or one of the 3, is speech therapy, and speech therapy really looks at somebody's swallow and communication following a stroke. So as Jarrelle was talking about before, there's different communication impairments that can happen. Some of it can be, I can't speak clearly, people can't understand me, I don't know how to get the words out. Another is, I can't understand what people are saying to me. So those are expressive and receptive aphasia. You can also have global aphasia, which unfortunately you don't understand what people are saying to you, but they also can't understand you. And there's a lot of different severities of these different impairments. Jarrelle showed that lovely picture of the brain, and you can see that a stroke is not a stroke is not a stroke. And people will often talk about how they've had a stroke, and they'll be surprised at how different it is, but it all depends on how big the stroke is, when it was treated, and what area it occurred. And so that's the big thing that, you know, we talk about with our patients is a stroke is not a stroke is not a stroke. So just because your symptoms aren't mimicking what your friend's stroke looked like, still call 911 because your stroke could be different than your friend's stroke. Speech is also going to look at your swallow. So the muscles, oh gosh, now I should have asked the speech therapist before I came up here, but I think it's like 36 muscles work together collaboratively in a lovely coordinated effort to swallow. Something so simple that we don't even think about as a swallow takes 36 muscles. And not only can a stroke affect your arm muscles and your leg muscles, but it can also affect your swallowing. And so we'll get into a little bit later, but speech therapy will also often do a very formal swallow assessment done in x-ray so that they can actually see where everything is going when you swallow. Occupational therapy will come in, and they're going to look a little bit more at your cognition, your thinking, your memory, all that good stuff, and then your daily activity assessment. Here at United specifically, we kind of separate the body in 2, and occupational therapy focuses more on the upper body, so what your arms can or can't do, your fine motor in your fingers, your ability to do your daily tasks such as grooming and dressing, bathing, things like that. Physical therapy is going to come in, and we're going to focus more on the lower half. So we're worried about how you're able to stand up, walk, go up and down stairs, what your balance looks like. Jarrelle mentioned those transient ischemic attacks earlier, those TIAs or the mini strokes or the warning strokes. So we see anyone that comes into the hospital that's had a TIA as well, because we know that a TIA puts you at a greater risk of having a stroke later on. So we want to do an assessment if you've been in with a TIA so that we know what your quote unquote normal is before you come in with a stroke, if that should happen. We know that not everyone scores perfect on a balance test when we give it to you when you're well. And so we don't want to try and hold anyone to this standard of being perfect when we know in all reality that's probably not where they were before. So yes, those are the 3 therapies. We all will try and fight each other to get in there and see you as quick as we can. In the meantime, you guys, anyone that's having a stroke is still having more imaging. They're seeing the stroke neurologist. They're talking to the nurse, getting education. And so it's a bit of a whirlwind in the first 24 hours, and it's completely normal to be overwhelmed by it. That's why we keep providing education and keep coming back to see patients on a regular basis while they're there in the hospital. As I said, this happens in the hospital room. So yes, you're still connected to lots of lines and tubes. We can do therapy connected to pretty much anything. Luckily, we have great nurses that are here with us, and we will get rid of any lines that we can, but there's a fair number that we still have to keep. And so we will make it happen, however many people it takes. We are committed to getting patients up and moving. The goals for this therapy in the very immediate time frame is just to get somebody moving. We want to get up to a chair. We want to go for short walks. So we're not necessarily going for really long walks, but even a walk to the bathroom is a good start. We're looking at the impairments that we're seeing from the stroke. So is the vision different? Do we have communication deficits? Do we have weakness in certain areas? Balance deficits? Some patients will complain of having that vertigo sensation. So we're just really working on identifying what those impairments are first, and then we can tackle treating them. As I said before, we communicate very, very closely with stroke neurology team. We have been a part of the stroke rounds. We participate in many of their meetings. We see each other on the floor. You will see the team come together, and we're constantly giving feedback on what we're seeing, things that we think can be maybe medically managed a little bit better, early identifiers of some future problems. So we're very, very involved with each other. So we talked a little bit about speech and the video swallow. So the video swallow is that very formal, sorry, phone rings all the time. It's a very formal assessment of swallow. So the speech therapist will have somebody eat or drink foods that have some barium in it. It sounds a little odd, but it's kind of laced with barium, and then they go into the X-ray suite. And what will happen is the speech therapist will have a patient try different consistencies of food. They want to see whether a patient can handle like thin liquid water. Usually there's some applesauce, there might be some pudding, and they're going to actually take an X-ray while you're swallowing to see if it's going into the windpipe and the trachea and into the lungs, or if it's going into the stomach, as it should. Typically, they're doing this because they want to look more closely at that swallowing. Initially, the speech therapist, when they're first meeting a patient, will do what we call a bedside swallow, and so they'll just have them, take a sip of water just to see if there's any coughing or clearing of the throat. They can usually give a pretty good idea for a diet initially after that, but they're still going to follow it up with this really close X-ray because we want to make sure that nobody's going to develop pneumonia on top of this. So after the video swallow, once the therapist has seen where that food is going, they'll recommend an appropriate diet. So there's 6 different diet levels, and I won't go into all of that, but just know that modified diets could include thickened liquids, pureed solids, easy-to-chew foods, and it all depends on where the weakness is and what the risk is of eating food. So, if somebody has a thickened liquid, you would think, well, thickened liquid will be better because it'll be easier for them to swallow. But if that thickened liquid goes into the lung, your chance of getting pneumonia is much higher. So the speech therapists are very well versed in this and are constantly making modifications to those diets and determining when it's the best time to upgrade. I'm gonna see if I can show you a little video of a video swallow. Let's see if it works. 1 second. Skip the ads. All right, so on the left, this is a video of a normal swallow. So when the person swallows, you will see that bolus, they call it. It goes straight down into the esophagus where we want it to go. And the second one on the right, that bolus of liquid, you can see one, that the swallow is not really great. It's not all going down at one time. And then you can see how it goes back and forth from kind of the right to the left side. That's because it's actually going into the trachea, which we don't want. Now help me get back. Okay. All right, great. So that's the video swallow. Transitional rehab, that second phase, it occurs when you're technically discharged from the hospital until when you get discharged to home or a community place. So usually it means one of 2 things. Usually it's either an inpatient rehab program or it's a transitional care program. It can also mean kind of going home with home care, but we'll get into that a little bit more later. So there's the big emphasis on transitional rehab is to keep strengthening, to continue developing abilities to be able to complete those daily tasks and that mobility more independently. We want to identify areas in which support will be needed in order to discharge home. So, you know, how much assistance would be needed to bathe? How much assistance would be needed to walk safely within the home? How much supervision is needed due to some cognitive deficits where maybe the patient is more confused than normal? We're really focused on identifying and obtaining any equipment that we can get that would enhance safety. So it could be just something as simple as a walker, it could be a wheelchair, it could be an alternative communication device, which is a fancy iPad-looking thing that's going to help somebody that can't speak be able to communicate their needs. There's lots of things for occupational therapy. You'll see shoehorns and reachers, things like that, that just make doing those daily tasks easier, but also allow somebody to be independent. Our goal is to make somebody as independent as possible. We know that nobody wants to rely on somebody else. We want to be independent people by nature. The goal is really to regain those abilities to a level that would allow somebody to return home safely, with or without modifications. So I'm going to talk a little bit about inpatient rehab versus transitional care. I will tell you I'm an inpatient rehab therapist. That is my bread and butter, so I love talking about it, but there's benefits of both of them. So inpatient rehab, it's more intense. So typically in inpatient rehab, we require somebody to do 3 hours of therapy per day, and we'll do it up to 6 days per week. So usually you get 1 day off per week. So 3 hours of therapy would be divided between physical therapy, occupational therapy, and potentially speech therapy if that's warranted. Here at United, and oftentimes throughout the metro, inpatient rehab facilities are actually housed as a special unit within the hospital. So here at United, our inpatient rehab unit is just on the 8th floor of the hospital. So it doesn't feel like you're in that transitional phase because you haven't left the actual hospital, but you've officially been discharged from the acute side of it and have been admitted to our inpatient rehab unit. So here at United and a lot of places, you'll stay in that hospital to receive your services. So the average length of stay is 1 to 3 weeks. We're licensed differently than transitional care units, so the maximal stay that we can really have is 3 to 4 weeks. Sometimes, even after 3 to 4 weeks, there's still more therapy needed. A patient's not safe enough to discharge home, and so there still might be a secondary stay required at a transitional care unit. And if that's the case, that's something that's coordinated while they're here on inpatient rehab. While on inpatient rehab, we'll see many providers. So like we said before, physical therapy, occupational speech therapy. We also have psychologists because everybody that's coming to inpatient rehab has gone through a significant life-changing event that they weren't planning on. And so it's not because we think there's something wrong, but because we want everyone to feel supported here. We also have a designated care manager and social worker that will help to obtain services and set up appointments following discharge. And then we have a physical medicine and rehabilitation doctor that oversees and directs the care here on a daily basis. Transitional care is less intense. So there's not specific requirements like there is for inpatient rehab. Usually in a transitional care environment, you'll get about 1 to 2 hours of therapy per day and 5 to 6 days per week. So it's still a good amount of therapy. It's just at a little slower pace maybe than what you would consider inpatient rehab. The average length of stay for transitional care is about 1 to 2 months. So people get taken aback by that, but depending on the severity of the stroke, 3 weeks could feel very, very quick, or 2 months is much more comforting. And it's really kind of figuring out what pacing and what intensity is the best. At a transitional care unit, there will be nurses, occupational therapists, physical therapists, speech therapists. You will also have a physician that sees the patient weekly. So a little less physician oversight, but they still are checking in daily. They're just not physically on site. All right, so outpatient rehabilitation happens once you are discharged to the community. So typically outpatient therapy is done in a clinic, though it can be home with home services. within Courage Kenny specifically, we have different outpatient therapy clinics. You've probably seen them around. One type is like a sports physical therapy, but we have actually designated outpatient therapy clinics that have a neurologic focus, which means that they have PT, OT, and speech all together in that clinic. And the diagnoses that they see are typically with a neuro focus. These are often housed within the hospital. So here at United, it's on the main floor of the hospital. Abbott, Stillwater, Mercy, and Unity, they also have clinics as well that are neuro focused. The emphasis in outpatient therapy really becomes, again, working more and more towards that independence. So in speech therapy, they continue working on cognition, speech, and swallowing. Somebody that's had severe communication deficits, this is typically when they get the augmentative communication devices, because it takes a lot of training and setting them up so that they're the most easily used for patients. Occupational therapy is going to continue working on memory, cognition, being independent with daily tasks, being able to make your own food, being able to get dressed. They work a lot on upper extremities or the arms, and then potentially also on returning to driving. For physical therapy, the goal is really just trying to regain the independence with mobility and balance, and then returning to fitness is a really big focus for us. Like Jarrelle said, exercise is important. Exercise after a stroke is just as important as taking your medicine. It can help prevent that secondary stroke. So that is one of the big things that we educate on in therapy, is that exercise is important. And it doesn't mean you have to be able to run a marathon. It can be a walk just in front of your house. The biggest thing that we try to educate on too is that most significant recovery comes within the first year following a stroke. It's not immediate. So yes, this is a long haul. This is your job for the next year, is to just keep at it and recover. We've seen so many medical advances. I've been here at United for 15 years, and the amount of impairment after a stroke has significantly lessened. My job has changed significantly because the medical advancements in treatment of stroke have improved so much over the years. So our big thing is never say never. My job as a physical therapist is to prove to you what you still can do. These are just some technology and treatments that we do. I know we're running short on time, so I just wanted to show a couple of things. Electrical stimulation is what we use to help muscles activate after a stroke. And so there's different, we'll use it in physical therapy and occupational therapy, and it sounds torturous, but it's just using a little bit of electrical current to help activate those muscles. So on the left, you can see this is called the BioNest. It's actually a wearable device that people will just have kind of clamped onto their leg, and it's providing feedback and activation throughout the day. A lot of times you can't even notice it underneath a pair of pants. On the right is for the shoulder. So oftentimes when the shoulders, when the muscles are weak in the arm, the shoulder will hang and become painful. So this is a way that we handle shoulder pain. High intensity gait training is a kind of a new standard here for stroke rehabilitation. So it involves us being really mean and adding weights to weak limbs and then just pushing you to work really hard and get your heart rate up. It sounds mean, but we're doing it for everyone's best outcome. The exoskeleton, that's what's pictured there. It's a robotic device that we can actually get patients up walking early without having to use 3 or 4 people, so it allows us to take a lot more repetition of steps. We have a fancy treadmill that we have a harness over top of, so we can actually take some weight off and let people walk even when they're having a difficult time. And then that bottom picture is called the Dynavision, and that's often what's used in kind of vision recovery and in pre-driving assessment. So those are just some of the things that you would see potentially after having a stroke and going through therapy. So I'm going to let Jarrelle jump in quick with the additional resources.
When you say an hour with our team, you get an hour. So Alina does what's called a stroke lecture series. So one of the events was in May, but there are still 2 that are upcoming, one in September on the mood adjustment and motivation after stroke. That'll be done by Dr. Kisser at our Courage Kenny Golden Valley campus. And then the other one will be in November on secondary stroke prevention, so talking about what you can do to lessen your risk of having another stroke. And this one will be by Dr. Diane Chapuis, who is a physical medicine and rehab physician here at United. She is absolutely incredible. I have not personally met Dr. Kisser, so I can't speak to how great they are, but Diane is amazing. If you can make that talk, I would highly encourage it. It is free. They do ask that you register. The contact information is there on the right, and I will include this in the email that I send to be uploaded. Additionally, Alina has support groups. These are specifically related to stroke. We do have other types of support groups as well, but these ones are the stroke support groups. I can include this information too in the attachments that I send. We do recommend you contact the group facilitators just in case the event has to be canceled that day for some reason, or it's in a different conference room. Things like that sometimes happen. And then also highly recommend, if you or a loved one has a brain injury or has had a stroke, that you reach out to the Minnesota Stroke Association or the Minnesota Brain Injury Alliance. They are very closely connected. They actually share a lot of the same employees, I think, between them. But they have a free resource facilitation program. Free is everyone's favorite word. So you can sign up online or give them a call at their 1-800 number, but they have connections to additional community resources and other support groups throughout the state, just in case you're not located near an Alina facility where we can maybe get some help. Any questions for Jodi or I?
Scott, you got something?
Not a question, but just wanted to make a comment how appreciative I am that you were able to be on for this and the great information you provided. Easy to understand, great charts. This is something that the world needs to know about.
Well, we are happy. Thank you so much for inviting us. If there's other events or, other organizations that might find this helpful, we're happy to connect with them as well. Spreading the word is really important to us because so much of it is preventable. As much as I really want to meet all the people, I want it to not be because they're in my hospital hospitalized for stroke, because hopefully we prevented it from happening.
Yep. One of the things that when you were talking about risk factors, there's a race is a risk factor. And I don't know if I heard this, but or I made this up, but specifically with stroke, stress is a big part. If you're under constant stress, does that increase your chance of stroke?
So constant stress can increase your risk for a whole host of things. Constant stress can increase your blood pressure. Increased blood pressure can increase your risk of stroke and heart disease, and unfortunately has a cascading effect throughout your entire body, which means it's hard to be an adult.
Well, and in America, where there's structural and systemic racism, it's hard to be a Black person. And I'd seen that many health outcomes were due to having to navigate, that life under the difficulty setting, under that difficulty setting. So it's probably the case for stroke as well.
Yes, yeah. So Black adults, unfortunately, do have the highest rate of death due to stroke across the country. And then that still holds true, I believe, for Minnesota. But in Minnesota, additionally, the Minnesota Department of Health, I think, all categorizes the Asian population as well as the Black population of having increased risk of stroke compared to the white population or Hispanic population.
Well, once again, I want to repeat what Scott has said. This was absolutely wonderful. We save our video time for the really, really good presentations. We used to put everything up on video due to COVID, but this is definitely going to be one that we can put forward and let folks know that it was here and that you were here. I just want to, is there any way that the two of you can get into the screen at the same time? We can get the Jarrelle, Jodi. There we go. So we can give you all a round of applause. Thank you guys so much for being here.
Thank you for having us.
Yeah. So the class does lunch and learns quarterly. Our next lunch and learn is going to be October 18th from noon to 2. And we also have coming relatively quickly our networking meetings, which we do every other month. September 13th from 8:30 to 10 a.m. is our next networking meeting. That will be a face-to-face meeting. We'll be looking at that probably come winter time. We'll be back on Zoom. Any other final questions? Charlotte, you're back on screen. Did you have anything you wanted to say before we signed off?
Not really. I think that was a great presentation. I'm 62 and my father died at age 42 of a stroke. So it's something that's always been on my mind, and it's so real. So I appreciate all the information, and just, we'll revisit it all the time. Thank you.
All right.
And Jarrelle, we will repost this, the recording and everything will be thrown out to all of our members and anyone who is on our list that receives things. So those who couldn't attend today, we do find that there's a lot of reconnection that takes place in these recorded events. We find that people do look at it later. So just because they're not here today doesn't mean that the information went lost. So.
All right.
That sounds great. Thank you so much. And whether it's now or recorded view later, if you have questions, please reach out.
Great. All right. I think that's a wrap.